You are host.
Thank you.
I need to move the ball from Arti to Harish when Arti is finished.
Okay, I move the ball.
No, not now. It's fine. Arti will start. She does the first presentation, and then it's Harish. And Harish and Dr. Prabhakar are together, so it's only a matter of moving the ball from Arti to them.
Okay, great.
When she's done. Thank you.
Okay.
Stand up to it. Leave controlling. पहले वो आरती का स्क्रीन शेयर करेगी जो then she'll share our. We are not sharing our thing to them. How will they share? Once we.
Harish, can you mute yourself, please? Thank you.
Okay, it's 12 o'clock in Geneva, but I think we will give people time to join. So let's wait a few minutes for people to join, and then we can start.
हेलो सुनाई नहीं दिया उनको हेलो
Yes, Arti, we're just waiting a few minutes for people to join.
Okay, should I mute myself?
Yes, please. Thank you.
Okay, so I think people take time to join, but let's not get delayed. So I will just go ahead with some of the house rules and give an overview of the webinar today. So first, I would like to say welcome to everyone. My name is Zainab Naimi. I work at the Department of Maternal, Newborn, Child, and Adolescent Health in Geneva, WHO headquarters. And you know, if you're used to attending these webinars, we have some house rules. I think my colleague Benedict Walter has posted them at the top of the chat box. But just to remind everyone, as you join, you're muted and we only unmute the speakers. We will have a question and answer session after the presentation. So if you have questions, please do post them in the chat room and then send them either to all participants or to all panelists as we are going through the presentation. And then towards the end of the presentation, my colleague will then read them out loud, noting who asked the question and what they would like to know or have clarified. So if we don't have time to answer all the questions today, we will share them with the panelists, and then they will be answered on our website in the following days. So just a bit of background as usual. The Network for Improving Quality of Care for Maternal, Newborn, and Child Health has been organizing different series of webinars on different topics around quality of care, and we try to focus on country examples. We've had several webinar series starting from point of care quality improvement. We had several examples from many of the 10 network countries, and also issues around WASH, importance of WASH for delivering quality care, and also linkages to the national direction on quality. I would also like to mention that more recently we launched a podcast, Quality Talks, that Benedict can tell you more about as we close today's session. So I hope you stay tuned for that. Coming back to today, we will be hearing about family participatory care in India. So partnering with families to care for small and sick newborns. I understand the experience came about when Professor Arti Maria and her team tried to make up for shortage of healthcare staff in newborn care by involving parents and relatives of sick and small newborns in the care of their baby, and then training them around this. So this was over 10 years ago, and the idea was later presented to the Ministry of Health and Family Welfare, and a pilot demonstration of this approach was implemented in 4 states in India, with the support of the Norway-India Partnership Initiative, which project director Dr. Harish Kumar, who's on the call, will tell us more about. So our speakers today are Dr. Prabhakar, Deputy Commissioner for Child Health at the Ministry of Health and Family Welfare, Government of India, Professor Arti Maria, Head of Neonatology at the Ram Manohar Lohia Hospital in New Delhi, India, and Dr. Harish Kumar, Senior Program Director at Japaigo, India. We will hear from speakers on how family participatory care started, how healthcare workers are now using it, and how the Ministry of Health and Family Welfare has turned it into a national program. They will highlight how the program involved families in the care of their newborn and how this changed the relationship between the provider and the person receiving care, and ultimately transforming the experience of care for the families and improving the quality of care delivered to the baby. So as we move ahead to explore this more, I would give the floor to our speakers, and I understand the first speakers will be Professor Arti Maria and Dr. Prabhakar. Please go ahead.
Okay. Good morning, good afternoon, and good evening, all the participants. I take you through the genesis and journey of family participatory care as it started in India. I take you to the year 2007 to a setting of a 16-bedded our referral neonatal intensive care unit of North India, which was having severe HR constraints. The state of newborn care was such that babies were being cared among incessant alarms. Babies were often wet. The tubes were often misplaced and not in place. The IV swellings were common to see. So this left us boggled with what to do, how to improve care. And outside, it was a common scene that parent attendants were lined up waiting most anxiously and in stress. The thought then occurred, can we start engaging these waiting parent attendants as nursing aides for their own babies to improve the individualized care for their own babies? And so we did start experimenting, each parents of the individual babies, they were called in, they were coached, they were coached and taught about simple monitoring, simple care of their own babies, and hand washing and getting entry and in being involved in care. And what did we see? We saw fringe benefits beyond what we expected. Parents were happier just to be by their baby's side. Babies were less often wet. More often the tubes were in place and babies were getting better quality of care. The nurses were happier because there was some work sharing. So that got me to understand that the conventional model of provider centric care is dominantly provider centric. And when it comes to care of a sick newborn, this is simply because of a competence gap right at the outset between the family and the provider. The provider assumes a role of power, control, and authority because of competence. The challenge for them is HR inadequacies, and the result is the compromised quality of care. The family only has a role of a passive receiver in silo, and their challenge is separation from their sick baby and parenting inadequacies at this time. The outcome is unmet needs of information, guidance, and support with mounting anxiety and stress. That got me to understand more closely the gaps this provider centric conventional neonatal care offers. That is, the less attention to sick babies' development and the psychosocial needs of family. The parental involvement in care and decision making is severely limited. The universal human workforce shortages lead invariably to compromised quality of care, and importantly, there is lack of continuum of care at home. So, family centered care can actually get a paradigm shift, and from power, it gets a equation of responsibility or work sharing. This leads to an almost a partnership in care between the provider and the client, the family, establishing a therapeutic alliance. The role provider now has one of work sharing rather than control and power, and outcome is quality improvement. And at end of the family, the role is now participative ownership through this partnership. They acquire caregiving competencies and trustful relationships are formed. The net result is improved health outcomes and establishing a linkage for continuum of care. So, what exactly is family centered care? Family centered care is an approach, it's an attitude, a mindset, a concept that aims to develop and nurture family's role in partnership with that of the healthcare team in care of a patient. We established evidence through a randomized controlled trial, and we could demonstrate there was no increase in infection, hospital stay duration was decreased, and there was substantial improvement in breastfeeding rates when family centered care was used to complement care of a sick newborn in the study. To standardize the intervention, we developed audio-visual training tools, which were structured into 4 modules. The first one importantly focuses on the entry protocol with due emphasis and learning to the mother about infection prevention and hand washing skills. The second part addresses the developmental needs of a sick baby and teaches the mother about developmentally supportive care, sponging, nesting, handling a baby, cleaning a soiled baby, interacting with the baby, as well as feeding, expression of breast milk, assisted feeding, and interacting with the baby. The third module is about kangaroo mother care, in which parents, including the fathers, were equally involved. The fourth module is about preparing parents and families for discharge and aftercare at home for these vulnerable babies, including the essential newborn care, the interaction, early childhood development, immunization, and picking up of danger signs. So, institutionalizing family centered care, the process really involves induction or sensitization of the family at the time of admission and identification of primary care provider who can be subsequently be involved in the daily trainings. And demonstrations and practice are the methods to train and impart competencies through demonstration practice. Then is the stage of supervised learning under the supervision of the nurse. And then peer to peer learning is fantastic. The one mother who's been there older period of time, she is teaching the new mother, and this empowers them truly. And then comes the stage of independent doing when mothers feel competent to do it alone. and then the stage of discharge counseling, and finally, a continuum of care linkage for care at home is established. So, what exactly does the implementation entail? It requires infrastructure and facility which are conducive to the maternal or the family's uh, family friendly facilities. We need to change attitudes of the healthcare providers for a successful implementation and practices which demonstrate involvement of the mothers in processes of care. These need to be present. And so, what is the aim of implementation? It is really getting mothers to participate in care of their babies through acquired competencies, and thus sensitization, capacity building, engagement in care, and thus forming a link for continuum of care after discharge is essentially what requires for implementation. What did we learn through the lessons? We really realized initially we were focusing on mothers as the biggest bottleneck, but it was much later that we realized that mothers is the most easy buy in. They just buy into this idea as easily as one could imagine. And the biggest challenge actually lies with the providers who form the biggest challenge for implementation. Why? Because accepting parent attendant as a co partner in care could be challenging. A feeling of diminished authority somewhere in the subconscious, a feeling of watchdog effect because the parent attendant is constantly there. There may be a tendency to task shift, and now they are expected to deliver a standard of care that now mother and parent who are informed are now aware of. So these could be the challenges possibly the providers face. We tried to establish measures and attributes of implementation. So, in terms of workspace readiness, parent attendant preparedness, and staff preparedness, we could demonstrate feasibility through the fact that parents or grandparents, so irrespective of the relationship, gender, age, and literacy, there was huge involvement across all these sectors, irrespective of these factors. So you can see two-thirds of the parents were males and who were engaged in care, and even about less than half were more than 50 years old, and one quarter of them were illiterate. The acceptability of this strategy was demonstrated through a qualitative study where we demonstrated primary gains in terms of empowerment, skills, and continuum of care being established, and there was definite improved patient staff relationship. We also demonstrated participation of mothers in care in processes of care as a measure of improved quality of care. The country scale up has been happening. We have developed various guidelines, operational guidelines, IEC material, and as my subsequent speakers will take you through the journey of scale up subsequently, which has been happening. So, to conclude, family centered care is a humane way to care. It creates an opportunity for lifelong bonding. It is a family's right to a respectful care, which we need to protect, support, and promote. The operational feasibility and acceptability in Indian healthcare setting seems to be promising. And so, my dear friends, family centered care, through this unique partnership between the healthcare provider and family, seems to bridge the gap between hospital based newborn care and home based newborn care for improving neonatal outcomes. And so, family centered newborn care holds the key for developing social accountability of health to achieve sustainable development goals. Thank you very much.
Zainab, are you here? Okay.
Sorry, Benne, I didn't realize I was on mute.
I thought
Should I
so.
pass on the presenter?
Yes, please.
Yes.
Harish, you have the ball now, so you can start your presentation. And Dr. Prabhakar.
Dr. Harish Kumar, you can go ahead with your presentation, please.
Harish, you're on mute. You need to unmute yourself. There we go. We can hear you now.
Thank you, Dr. Aarti, for paving the way for NIPI to start a model of implementation which demystified the science to art of implementation and subsequent scale up in the country. In fact, this wonderful partnership between Norway India Partnership, Government of India, and Ram Manohar Lohia Hospital, which is a tertiary center, into that 5 model centers which were established sometimes in 2015 with 14,000 parent attendants who received empowerment through this unique initiative tripled its effect by the end of 2017, that almost 70 centers had come up in the country, and with a unique benefit that KMC sessions, which was one of the weak link in the MNCH coverages, to go up significantly high because of this unique initiative. So FPC, which started in 5 centers in a year's time, rolled up to almost 69 centers with country's budget in a span of less than 1 year. So I'll take you with this the dream journey. How come a small initiative could be rolled out countrywide? Before I tell you this journey, let me give you the rationale that how and why we designed this unique innovation. Country-led assessment of quality of care of children, which included newborn, threw up a challenge, and along with it, there was a Oxford Policy Management evaluation when Norway India Partnership started its work that there were significant issues with quality of care in district facilities, so much so that almost 10% of the newborns after discharge from these high-end facilities were subsequently dying in the community in a span of 1 year, majority being in the first month after discharge, and there were low KMC rate just to the tune of 1 to 2%, and country was looking for initiative how to break this bottleneck of improving the KMC rate, which is a global best practices. We looked at, do we have models? While it was a clinical best practices in select hospitals, mainly in the West, and now with the coming up of the Ram Manohar Lohia Hospital work, which showed the biggest bottleneck, which with whatever persons we discussed in the country, the hidden fear that can it lead to increase in nosocomial infection, and once that constraint was put to rest, this led to its rapid scale up in the country. To take you through this dream journey, 2014, after this assessment of quality of care and the RML work, which showed not only global but global experiences, there were almost more than 14 countries which have been implementing this work. There have been almost 10 meta-analyses, and the biggest gains have been in terms of psychosocial improvement of the maternal health, while there have been variable gains reported for the newborns, for the health providers, and for the health system. 2015, Norway India Partnership Governing Board, which constitutes the Secretary Health, which is the topmost position in the country, they gave approval that under this project, let's do some pilot testing. So design thinking and implementation process started in right earnest. By the end of 2015, we came up with 5 models. They started yielding results till 2016. And along with this, the concurrent advocacy was done by the state government themselves. They visited those 5 centers and decided for the scale up, so much so that by the end of 17, there were almost 70 centers which were using this novel modality of empowering the mothers. Let me give you a little bit of details of what was the contour of this model. The 2 questions which were asked to us anywhere and everywhere we went: will we need additional human resources? Does it mean additional workload for the existing constrained staff? And what will be its impact on the nosocomial infection? Work done from Aarti Maria put to rest that nosocomial infection does not increase this. So with this approach, we had discussions with the facilities, with the actual workers, and with the community. And this led to defining, synthesizing, interpreting data, and we came up with a human-centered model. This model was ideated by RML, Government of India, State Health Society, and various technical advisory groups, and a prototype was developed. This was further tested and put to use in 5 places, and which lead to that this model is a doable model, and this model was centered around nurturing care framework with the highest focus on developmentally supportive care, a piece here to missing from the Indian context. We sat down, and in this human-centered design model, we constituted 2 components. Under continuum of care model, facility component, which was targeted towards improving provider skills and empowerment of the mothers. So the biggest challenge here was changing the attitude of the providers. While people like Aarti Maria, they were already convinced. We needed to convince every facility, doctors and especially nurses. In terms of providing infrastructure, some draft operational guidelines were created, which, with the help of the national government, they culminated in the development of the national guidelines. We had to work on the audiovisual package, make it consistent with the country's policy. We had to redefine and re-ideate after discussions with the state government, and that led to finalization of the training package, which was put to use countrywide. And we continued this not only in the facility in terms of improving the practices of the mother through supportive supervision by the nurses, but continued the work in the community also. The community follow-up included that we had 2 peripheral workers, ANM, which is a medical worker, and an activist called Asha. The care at SNCU was continued by empowering the mothers through building her capacity in terms of adherence, that is compliance with discharge instructions and continued breastfeeding, continued support for kangaroo mother care and low birth weight feeding, adding a component of play and stimulation as per WHO guidelines, and promoting detection of danger signs so that survival and development, they are implemented in an integrated way. The outcome was mind-blowing. What the earlier mortality showed, 9 to 10% mortality after discharge, this got reduced to less than 1% in a single year's framework of implementation. So what is all that we did? We sat down with all key stakeholders, and the first job was, and that to my mind is the biggest challenge, convincing them. Second, we had to do their capacity building. So here we used RML at the national center, and in each state we utilized existing SNCU district hospitals for capacity building of the other SNCUs. Identification of a champion, especially nurse at the district hospital, was one of the biggest jobs. Having achieved that, our team did the gap assessment, and refurbishment was done by the state health societies. Towards all this work, we developed various tools which were developed at the national level but translated into local level at the local level in local language. We developed, in addition, a monitoring framework as to what is it that we want to achieve. And as we mentioned, our framework was embedded in the nurturing care framework, with KMC getting the highest priority. We developed recording format and reporting format, and once the state started implementing it with the country's budget, we did an initial quality assessment, and simultaneously, both at the national level, along with the government and along with RML, we started advocating for scale up countrywide. So the national and government, state governments, and this was the first learning we acquired, that if you keep the national government and state government involved from the beginning, it leads to rapid scale up, and there is no additional HR, which was one of the biggest concerns of state governments and the national governments. These are some of the advocacy steps. We had a call to action meeting daily where Prime Minister of India himself witnessed it. We had to go to the states to convince the key stakeholders, including medical people as well as the key bureaucrats. We had to do advocacy using public-private partnership forum. We had to do translation of the work, and we supported statewide launch. And this caught the imagination of not only bureaucrats but also politicians immediately. And what the results were, that we took two basic indicators. The first one, as per the adherence standards, that facility follow-up rates improved by 12%, but biggest gain was in terms of KMC rate, which improved from 2% to whooping 73%. So adherence, especially breastfeeding and KMC, they got significantly improved. When the states started implementing it themselves, we wanted to be sure what is the quality, because coverage without quality doesn't have a meaning in MNCH. 69 facilities by end of December, they were reporting that they have started implementation. Of that, 43 were submitting through reports of the number of cases which they have been managing. Out of these 43, we assessed 38 facilities. This assessment was both qualitative and quantitative, and this showed that almost 80% of the facilities, they were allowing family members, which was not being done earlier or was being done only for breastfeeding purpose for a very select short duration. And more than 70% cases, it was actually observed that they were providing family participatory care in one way or the other. The biggest satisfying point was that all logistics and enabling factors, such as providing them protocols or availability of the chairs and logistics and training space, they were in place. The only thing which were of concern and which we haven't even sorted out till today, what should be the sequences of the training sessions? Some places mentioned we should start by one and gradually go to second, to third, to fourth. Other places, they were thinking that we can club the session. We left it to the individual clinical providers that they take the best out of it, that how do they train their mothers, and data recording was to the tune of 97%. The key findings showed that yes, it's a doable and it was started everywhere. 72% eligible newborns were receiving family participatory care, although we don't have a global definition. How much should be the minimum time? The average time in our work showed that more than 4 hours was being spent by the families once they enter. Enabling logistics is not a major challenge, as government is making provision of most of these enabling supplies, and breastfeeding and KMC practices have improved significantly. So it's a doable model, and it can be a winning strategy for improving KMC and empowering the families. So this shows a paradigm shift that involving mothers can lead to a bottleneck in terms of our MNCH coverage of improving KMC rates. Convincing key stakeholders that they don't need additional HR, it doesn't lead to additional increase in the infection rate, or the ARTIS work which showed that there is no nosocomial infection increase rate. There are some studies from the West which have shown that there is again no increase in infection, was the one which was the key step in convincing them. Adequate infrastructure, which is a very unique requirement, was being provided, and in India we don't see this as a challenge, but maybe of concern in low middle income countries. But the biggest factor, and that is identifying a champion nurse at each institution, is the key to success. I'll thank you, and maybe I can give it to Dr. Prabhakar to share how he scaled up countrywide.
Thank you, Dr. Harish. Before we go over to Dr. Prabhakar, I would like to remind the participants that if you have questions or comments, please type them up in the chat box and send it to all participants or all panelists so we can make sure that we can bring them up in the question and answer session. So this is just a reminder, and I will hand over to Dr. Prabhakar.
Thank you, Dr. Harti, for setting the stage very nicely. They already how they went about doing it, and as a national government, we had our stakes. As you know, India has the highest birth cohort in the world of 25 million, and we also have high neonatal mortality, even though we have done good progress in the last few years. Yeah. And we are committed to bringing down the neonatal mortality and achieving the single-digit NMR by 2030. India launched an India Newborn Action Plan to bring down neonatal mortality and stillbirth in 2014. And as per its commitment, we are providing continuum of care across life cycle as well as from facility to home and in the community. And one of the unique features of this India Newborn Action Plan has been that we are having a pillar of sixth pillar, which is going beyond survival, that is care beyond survival, and this provision of family participatory care and kangaroo mother care and developmentally supportive care for our newborns who are sick and small and admitted in our special newborn units is a very fits in very well with this aim of ours. Next. So we had done good progress in last few years. Our rate of decline in NMR has been better than the global average, and also the birth asphyxia as well as the infection rates have fallen significantly in last 15 years. In fact, it is almost 2/3 fall in infections and more than 3/4 fall in birth asphyxia. But the cause of concern has been increased in the preterm and low birth weight morbidity and mortality. And kangaroo mother care guidelines had been issued by the Government of India in 2014 for providing care to low birth weight and LBW, low birth weight and preterm babies. We in India have a continuum of care for newborns under the National Health Mission, which has the strategy of reproductive, maternal, newborn, and child health as a continuum of spectrum, in which we have two major pillars. One is facility-based newborn care, and other one is home-based newborn care. In fact, we are encouraging institutional deliveries across the board, and we are reaching almost 80% institutional deliveries as in the national average. And each of the delivery points, we are providing essential newborn care through special solution newborn care units, and also special newborn care units are provided in all the district hospitals and medical colleges. These are 12 to 20 bedded and even bigger center with state-of-art equipment and special HR and trained for providing newborn care. As on date, we almost have 800 SNCUs across the country, and these are supported by at a lower level by newborn stabilization units. And we are providing continuum of care in the community after discharge of these babies through our, as Harish mentioned, accredited social health activists who are the peripheral most frontline health workers for our community, who are more than 1 million in number, and they have covered more than 10 million newborns have been visited in the last financial year 2017-18, and about 240,000 newborns have been referred for various ailments or suspected problems. And we also have an entitlement program under which all pregnant women and newborn up to infancy are provided complete free treatment, referral transport, diagnostic, free drugs, and diet for mother during the stay of the hospital under a program called Janani Shisu Suraksha Karikram. So these were the settings which were a nice platform for us to launch the family participatory care, as we call it, which we adapted from the family-centric care as piloted by NIPI and Dr. Aarti Maria. We also know that, as Harish mentioned, 10% of our newborns are lost to follow-up or they die before completion of infancy following the discharge from the SNCUs. Also, the 41% of total admissions in this were in the age group, weight group 1.5 to 2.5 kilograms, and 36% of these were preterm. So these babies required kangaroo mother care, breastfeeding support, developmentally supportive care, and infection-prone measures. And also there is huge high caseload in these facilities. After establishment of SNCUs, we have a very good utilization of these, and we have referrals from all across the districts, which has led to very high doubling or even tripling of babies in the under the radiant formers. And one of the findings from the family-centric care was that it reduces the duration of stay of the babies in the SNCUs, along with the fact that they encourages kangaroo mother care. These two factors, along with the fact that mothers of the babies or the parents are encouraged to take part in the care of the babies, which helps them in continuing the care when they go back in the community, encourages to adapt this at the national level. As you know, India is a federal government with more than 29 states and 6 union territories, and each health is a state subject. So we adopted this at national level as a pilot project of NIPI in 5 districts, which was further further examined at the country level, and we developed the national guidelines, operational guidelines to suit our conditions in our public health facilities. So this was the principle that we have to develop the guideline so that the mortality and morbidity will be reduced, and their need for continuous care of a low birth weight will be established through establishment of family participatory or family center care, and continuous care will be provided. Mothers and families will be empowered. In fact, in India, the parents have a very significant role in care of not only their newborn but also children, and they spend a lot of time outside our SNCUs as special newborn care units when the babies are admitted. And this was a good opportunity that their waiting period is fruitfully used, as well as they feel they are empowered to be part of this treatment process, because the commonest complaint and the problem is to arise when the parents used to feel neglected and they are not informed adequately that what's happening to their child when they are kept separate from the from the families in the SNCUs. So we adapted the family participatory care from the family-centric care module. We changed the nomenclature to suit our sensibilities, and we also restricted the use to those newborns who are more than 1.5 kilos, newborns who are not on IV fluid or oxygen or on acute state of illness, who are very stable, and we are as such encouraging breastfeeding and express breast milk for those who cannot feed in our SNCUs, and these babies who are stable and in a position to take feeds were encouraged to be part of this thing. Only willing parents were trained, but in the Indian context, as Harish mentioned, mothers and parents are very easy to convince because they were always keen to participate, and they did not find it as any burden. In fact, they felt it is a natural progression. And there is prioritization of high caseload facilities was done, and we also benchmark the qualities that a facility should follow and meet to undergo this thing, so that we don't just open the gates of our SNCU to every all and sundry and compromise the quality of care being provided. Also, the resources were made available under the National Health Mission for the budget purpose of the states. The capacity building of the providers was done, which was a very important this thing, because the people who are providing service, they had to be enrolled into this process, because they should not feel that they are under threat or they are under watch, as Arti also mentioned. And we also had to make sure that our facilities meet all the standards and they follow the standard operating protocols, so that when their parents are inside, they don't feel that there is something going wrong or they give reason for them to complain. So this was extra care had to be taken, and so we were very careful in letting this the gates of the SNCU open for everybody to come in, because we at one aspect was in controlling infection. Other aspect is that we had to first meet as a public health facility the basic standards, and we managed to do that. Now, as Dr. Harish mentioned, we have done good progress. Many of now, as on 2017-18, 104 SNCUs are online, are in this providing these services, and many people in this, both staff nurses and medical officers, have been trained. In fact, the staff nurses were playing a very critical role in this, because They are also doing the coaching of the parents, and we are providing place in the SNCUs where the parents can be trained, and the mothers are coached in how to handle the baby and what is the hand washing practices and infection control practices and how to be supportive care and what is expected of them in the modules that Dr. Hari showed. And we have providing KMC also, and which has shown good progress as thing. So as a way forward, states have submitted proposals in the annual their action plans for gap assessment and as well as what they will require. The budgetary requirement are minimal, but they are very critical, especially the capacity building, for which we are providing the support under the same head as Kangaroo Mother Care. We don't want this to be a separate standalone activity. This we are very clear. We want it to be integrated with the facility-based newborn care, under which we are also providing Kangaroo Mother Care. And also we are trying to integrate this as a part of all other activities like National Quality Assurance System, which is under the National Health Mission, which is accrediting the units. So if FPC will also be one of the criteria in which this will be included. And Indian public health standards are under revision, and we would like to include these also in the. Another aspect we have done in the last year is that we are developing our special newborn care unit into mother and newborn care units, where the mothers or the babies who are admitted, especially the outborn babies, will get a bed and also counted as inpatient, where she will get all the benefits of a admitted patient, which since most of the cases she is also postnatal mother, and she can provide the support to the baby, provide care for the baby, breastfeed and Kangaroo Mother Care, and also complete care for a baby as soon as baby is stable. So the baby's stay in the SNCU will be reduced, time will be reduced, and the comprehensive developmental support care is given. And we are also encouraging the state resource centers for facility based to provide integrated support, and we are ready to share this with all the developing countries and neighboring countries who are interested in this thing. So we have made good progress in the last few years, but the real challenge lies ahead, because many of the states which are yet to take up will require a lot of support, in which we are counting upon our development partners, including NIPI, to provide this. Thank you very much.
Thank you, Dr. Prabhakar.
Thank you.
Bene, do you want to take over or with the questions?
Yes, sure. First, thank you to all the speakers for really keeping time as much as possible. It's not easy with 3 speakers and so much to say and so much content. We've got a few, one comment and at this point 2 questions. People on the call, keep typing your question in the chat box and we'll read them now. First, we have a comment from Deepak Gandia. Harish, can you mute yourself, please? Thank you. We have a comment from Deepak Ganvier, from Anil Nagendra, but he used the screen of Deepak Ganvier on behalf of GPI Go, saying that he feels, or she feels, more teaching institutions should now start working with family-centered care, because this will send the right message to peripheral public health facility and encourage them to also take family-centered care as soon as possible. Do you have any comments to make to that?
Bene, can you repeat who the question was for, perhaps? Bene, you're on mute in case you're speaking.
Well, this is not my day, sorry. I would say this comment was made during Harish Kumar presentation, And Anil Nagendra said that in his view, or her view, sorry, I don't know if it's a man or a woman, say more teaching institutions should now start working with family-centered care because this will encourage peripheral public health facility to do so as well as soon as possible. So more teaching institutions working with FCC.
In fact, can I respond?
Absolutely.
In fact, thanks Nagendra for bringing in a very important point to highlight that what have been missing from the Indian piece was that all the attention was only in strengthening health system, HR, logistics, equipment, and their capacity building. This is a game-changing phenomena which is happening that we are bringing in the perspective of the client, where the paradigm shift of allowing mothers into a intensive care area of a facility and their empowerment can actually lead to what we desired the most, that is empowerment of our communities. For challenge today in India for the newborn care is survival of the sick and small babies, and unless that is continued with the empowerment of the mother both at facility and community, all our efforts may not give us the desired results. And let me congratulate the Government of India and especially RT for paving the way for starting this initiative. And this has caught the attention of the health providers, the key stakeholders, with the result that states after states are coming up with requests to the national government for scaling it up on a very rapid scale up, that we are worried that yes, quality needs to be maintained in them. As Dr. Prabhakar rightly highlighted, that it's not only coverage, but it is the quality which is most important. And while we scale up, we need to improve the capacity, the quality of implementation.
Thank you very much. There is now a question for Dr. Prabhakar on his presentation from Ravichandran Purani, saying that they're interested in knowing how the home-based care takes place and who is the personnel conducting the program. Their area of interest is on reducing mobility, so particularly the developmental outcome at newborn and how to get registered for the program. So how is the home-based care taking place and who is conducting this program?
Hello. The home-based newborn care program in India was launched along with the facility-based newborn care in 2011, in which this is carried out by ASHA worker, the accredited social health activist, which they're from community activist, health provider from the community who is selected by the community, and they are making scheduled visits to the newborns during the first 42 days of life, on 3rd day, 7th day, 14th day, 21st day, 28th day, and 42nd day of life. In case of home delivery, they make visit on the day of delivery also. They are providing basically care for newborn and postnatal care for mother. Apart from counseling and also on improving community care practices, hand washing, they are also taking weight of the baby. They are taking temperature of the baby to make sure the baby is not hypothermic or having fever. Then also counting the respiration for any respiration. In fact, basically they are looking for the danger signs. And if there is a danger sign, they counsel the mother and take minimal essential action to take care of the baby and then refer the baby to appropriate place. Under JSSK, we have assured transport system, which is free of cost. There is a centralized number in the country for each state, 108, 102, the ambulance services, which they use for transporting the baby to the nearest center of our health facility, which could be SNCU or lower level, depending upon the availability. And they are also doing the follow-up. This is very critical. When the SNCU babies are discharged from this thing, they start the home visit from the day the baby reaches home. Suppose the baby stays for a week after birth and goes home on 8th day, they will start the 8th day as first day of listing and continue the same visit on 3rd, 7th, and so that we know that the critical period after discharge is the first week. So again, that period is covered. And they are given incentive for this to make the home visits. And there is a monitoring system to find out how they are doing. And there's a supportive supervision by ANMs, that is auxiliary nurse midwife, and also ASHA facilitator who make it's a supportive visit as well as check so that there is a quality is improved of the visits and they provide quality service when they are visiting.
Thank you for this reply. I have a question for Dr. Harish Kumar from Arun Jadon. A very specific question on the duration of contact to be considered. Ati, can you please mute yourself? Thank you. To be considered as continuation of KMC at home. So what duration that's required, and also at which day is it assessed after the discharge of the baby and the family?
In fact, if I have to break up this question into two parts, one is the duration. While we have global WHO guidelines which mentions for the KMC minimum duration is 1 hour, that we say that it's a KMC. For FPC, there are no such global standards, and that's a potential research opportunity which we in our project, based on some of the research which was published way back, sometimes in pediatrics, laid our standards to around 4 hours. That research study had included FPC around 6 hours. This was a Delphi approach based on discussions with the technical advisory group, which suggested that unless there is a minimum of 4 hours, these 4 hours were decided based on the fact that in those 4 hours, there will be at least 2 episodes of feeding the baby. There will be an episode of cleaning the baby. Mother will get an opportunity to talk and play with the baby as well as provide KMC. So with that, but this is, I agree with you, is a potential research opportunity. How much minimum time we should say when the mother is spending continuously in a facility to label it as family participatory care. The second is about continuation, because if you look at the WHO evidences on community practices, adherence is one of the weakest link in terms of counseling, in terms of advice, in terms of continuation of the medicines, or in terms of follow-up in the facility after discharge. So towards that, this community component helped us improve breastfeeding, which is generally advised at the time of discharge, helped us improve KMC, kangaroo mother care, which was not increasing because although the mothers were providing some of it in the facility, but they were not continuing in the community, for they were not sure and they needed some kind of an encouragement and continued support. And the third thing which it helped was that it helped in bringing back those cases which needed higher attention back to the facilities. So towards that, it helped us improve adherence standards. Uh, in terms of FPC, the research is again needed as to how much mortality reduction it can bring about, because it can lead to improvement in certain intervention coverages. But how much it will translate into mortality reduction, that is something to be seen. But in India, we found that there was tenfold decrease. 10% of the babies who were dying earlier. Another research study showed around 7%. And here, uniformly, mortality rates were less than 1%. Although follow-up has been only for first 1.5 months, but this is the prime time when most of these mortalities happen.
Thank you. There's two last questions for Professor Maria, and I think that we need to stop. The first one is from Jyoti Benawi, who said that the involvement of male members of the family should really be encouraged. And I think, Ati, you mentioned that in your presentation and how you went about this. And the second one is broader, is about to do with perception. And you also touch on this in your presentation. How do you implement family participatory care in a community where it's difficult to convince people? And it has all to do with the change of attitude you mentioned.
Yeah. Okay, so I just talk about the male members' involvement. It is, I think, it is natural, and it comes in very naturally when the mother may not be available right in the beginning, because ours is a referral unit, and many places it is so that the mother is somewhere else delivered and the sick baby is brought to the special newborn care unit. And in that situation, the fathers and grandmothers, grandfathers, they tend to be there. And what we have seen is that the involvement or grandfather involvement comes so naturally, and in fact their involvement and their experiencing the care of a sick newborn and being involved with processes of care actually tends not only to build and their capacities and their being bonding with the baby in this early critical period of childhood development, but also this tends to give a very respectful image even to the mother. So I have seen actually that the fathers would start respecting the mothers much more when they have been through this journey and involvement in processes of care. So it's really fantastic and phenomenal to see the bonding with which they attach with the sick newborn. Otherwise, this would be a missed opportunity because parents, especially the fathers, are completely absorbed from this opportunity.
Thank you. And the second question, yes, go ahead. Go ahead.
What was it, Benedict?
The second question was to do with perception and how to implement family-centered care in a community where you have to convince people and it's difficult to do so.
Yeah, as I mentioned, through iteratively learning and experiences, we learn that families and parents, they are just waiting to be involved. So that is not a challenge at all. The challenge is of the provider being involved and bringing about a mindset change in the provider, the healthcare provider, nurses and doctors. But let me tell you, at the base of our hearts, all the providers, they intend to provide the best of the clinical care. And the health experience and the perceptions of the parents gets transformed so much that it is such a visual experience of the providers to feel that they are actually delivering a satisfying health care through family participatory care, and that is why it becomes much more easy for them to change their mindset once they have experienced that how much satisfying experience they are able to deliver to the mother and the families. So it actually works in a very positive feedback way. So the mothers get a good experience, the doctors and the nurses get a good experience of delivering that good experience, and then they get into it because they feel more satisfied providing good quality of care.
Thank you so much. Very quickly, I just want to tell for the people who are listening in, who joined today, that Professor Maria actually had an episode of our Quality Talk podcast about this, about a personal experience in pioneering this approach for the last 10 years. So I sent the link in the chat box if you want to listen to this podcast. We'll post the presentation on the website. I'm handing over to Zainab to close.
Thank you, Bene. Today's webinar was very, very interesting. And as you know, in the network, we're always looking for examples of how new approaches that are being tested can be scaled up and institutionalized. And I think this was a great example of that, but perhaps it also shows that it does require continued commitment and it doesn't happen overnight, and then it takes time to scale it up to this level. And I also wonder how this approach could be applied to other population groups, but I think that would be for another time. And another thing I noticed is the complementarity across the approaches. So in the training methods that you see peer-to-peer educations for mothers, and then addressing the continuum care in the community and how it ultimately improves the relationship between the provider and the client, and also the complementarity of approaches when advocacy was done for the findings towards the scale up. So it was overall very, very interesting. So I would like to take this closing to thank our speakers for sharing their experiences from how this started and how it's now reached to the level of a national program and then integrated in the quality assurance program as well. Thank you, Bene, for moderating today. I would, of course, also take the opportunity to remind you that this is recorded. It would be online on the qualityofcarenetwork.org. So if your colleagues didn't have time to join today, they can listen to it later and also find previous recordings. So I think thank you to everyone, especially Dr. Harish Kumar, Dr. Arti, and Dr. Prabhakar to taking the time for this. And you'll hear from us soon on the next webinar. Thank you.
Thank you very much.
Oh, thank you. Bye.
Bye.
Bye.